Clicking start. Hello, hi everyone. I can see we are streaming in. I will give us 1 to 2 minutes before we start the webinar. I see we have more people joining. I'll give it another minute. Okay, I think we'll commence and the others will keep streaming in as we continue with our session. So thank you all. Good morning, good afternoon, depending on where you're joining us from. Welcome to today's webinar, which will focus on findings from the Tobacco Control Data Initiative, Kenya's research on morbidity, mortality, and economic costs of tobacco use. My name is Winnie Awur from Development Gateway, and I will be the moderator for today's webinar. I am joined with my colleagues from WHO, AMREF, KEMRI, and the fourth one is University of Nairobi. To start us off, we will have Dr. Maina, who is a tobacco control advisor at the WHO Regional Office for Africa. He will set the scene on the global trends of the burden of non-communicable diseases. After this, we'll now narrow down to the Kenya experience. And here we will have Dr. Jane Ong'ang'o, who is a director at the Center for Respiratory Disease Research at KEMRI, present on prevalence patterns and factors associated with tobacco use among patients with priority tobacco-related illnesses. After the presentation on morbidity, our third panelist is Dr. Lazarus Odeny, who is a statistician and public health researcher with AMREF Health Africa, and he will present the findings from the mortality study, that is mortality related to tobacco use in Kenya. And finally, our final panelist is Dr. Daniel Mwai, who is a leading health economist and health financing specialist, and currently serves as the presidential advisor on health. He will be leading the session on costs related to tobacco use. Just a bit of housekeeping before the first panelist kicks us off. We will have each panelist make a presentation that should last about 10 minutes. After this, we anticipate that we will have time at the end of the presentations to just for Q&A sessions. So I do urge you to just drop in your questions through the Q&A function, and just after every presentation, please feel free to drop your questions there. We will bring some questions to voice, and we will respond to other questions directly on the Q&A chat. Without further ado, I will turn it over to Dr. Maina.
Thank you, Winnie, for the invitation. I will share my slides. Give me a second. I hope you can see my screen. Please confirm.
Yes, we can see it.
Okay, thank you. First of all, I want to thank the DG for inviting me to be part of this webinar. And in the next few minutes, I'm going to just present a snapshot of NCDs in the African region, and then link this to the burden of tobacco use and the policies that are there in the region and the shortcomings that we face as the African region. I decided to zero in to the African region because the country we are discussing today, Kenya, is actually part of the 47 member states of the WHO Regional Office for Africa. Now, when you look at the global burden of disease, you'll find that the world now, most of the people who die in the world are dying out of non-communicable diseases. And the only difference in this is that in the African region, we still have a high burden of communicable diseases, and therefore non-communicable diseases are on the way to catch up with the communicable diseases in terms of the total number of deaths that occur every year. Now, this trend is changing because we have an epidemiological transition, and the NCDs are increasing as our efforts to control communicable diseases are yielding fruits. Therefore, by the year 2030, we'll see the burden of NCD-related deaths equaling the number of communicable disease-related deaths. And that trend, if not addressed, will continue to increase thereafter, to the extent that now the African region will more or less be tackling issues related to NCD other than the high burden of communicable diseases. And by 2050, most likely nearly 3/4 of disease burden in terms of deaths will be due to non-communicable diseases. And this needs to be addressed. Now, why are we talking about this? We are talking about this because even though we find that the African region has actually, in terms of comparing communicable and non-communicable diseases, you find that probably the burden of NCD in terms of absolute numbers might be slightly lower. But when you look at the disease burden in terms of disability life-adjusted years, you find that actually non-communicable diseases carry the highest burden of disease. And therefore, when you look at the age structure, most of the deaths, particularly for the adults, are actually related to non-communicable disease, much higher in most of our countries than the global average. Therefore, NCDs are not a problem to be overlooked, but actually a leading cause of death in the African region. Now, we have various issues, but when you look at our economics in the African region, is that we are still struggling with the challenges of economic development, meeting health budgets, But when you look at the burden of NCDs, is further exacerbating our poverty because it's costing more than 40% of the loss of productivity in our region. And when we address NCD, we are not looking at the public health problem. We are also looking at a social and economic problem that needs to be addressed. However, we have challenges in the region. We do not have good policies that address the prevention, control, and even management of non-communicable diseases. For example, only 3 countries in the African region have proper data indicating the mortality, particularly those associated with non-communicable diseases. In most of the countries, we find that we don't have regular surveys, we don't have accurate data, we don't have data that reflects the situation of non-communicable in these countries. And only a few countries have policies that regulate some of the risk factors, including trans fats or reduction of salt in diet that would address problems like hypertension. Now, when it comes to service delivery, it's the same way. Most of the countries in the African region still are struggling with health systems that do not actually address non-communicable diseases. They were primarily put in place to address communicable diseases. For example, as we speak today, 58% of people with hypertension in South Africa are actually having unmet needs as compared to about 22% for those with HIV. So there's more emphasis put in communicable diseases than in non-communicable diseases. And when it comes to diabetes, we find almost 93% of all people with diabetes have unmet needs in the African region. This is a gap that needs to be addressed moving forward. Now, when you look at the available resources, you find only 2% of the development assistance to health in the African region actually goes to non-communicable diseases. The rest, 98%, is focused on actually prevention, control, and management of communicable disease. How do we actually change this imbalance? Looking much closer to tobacco, then you'll ask yourself, why are people dying in the African region? And when you look at this graphic here, you will see that majority of deaths in the African regions are arising from neoplasm, that's cancers, chronic respiratory diseases, cardiovascular diseases, and diabetes and kidney diseases. These are a common disease that we see in our hospitals, and yet, like I said, prevention and control is still undeveloped. And when you look at across all these diseases and look at actually the key risk factors, tobacco use becomes the leading risk factor for these killer diseases. Therefore, tobacco use remains the leading cause of death in our region as much as it causes death in other regions. And when you look at how far we have achieved in terms of controlling it, you see differing levels of implementation across various countries. So that when you look closer at the situation in the region, we have a very mixed pattern of tobacco control in our region. However, I have some good news. 40% of our countries in the African region are actually on track to achieve the 30% reduction in tobacco use by 2030. So we can do more. But unfortunately, 4 countries actually do not have, are not actually achieving this. And actually, we are seeing an increase in tobacco use in those countries. Over to you, and thank you.
Thank you so much, Dr. Maina, for that presentation, for just showing us.
Sorry, my room has gone into a blackout and I've lost power. I'm in the dark.
Sorry about that. But thank you so much for that presentation. I'd encourage our participants to just drop any questions that they might have in the Q&A function while we still have Dr. Maina on the call. Next, I would invite Dr. Ong'ang'o to present. So Kemi, if you could please bring up the slides.
Good afternoon, or good morning, or good evening to all of you. And I'll now talk about what Dr. Maina has just mentioned, tobacco use.
Jane, just one minute. Kemi, can we have it in presentation mode, please?
Right, go ahead.
Okay, I think if that's what we'll have, it's okay, we can still proceed. Thank you. Go ahead, Jen.
Thank you. So I'm going to discuss about tobacco being a risk in some of the tobacco-related illnesses. Dr. Maina has mentioned that tobacco remains a risk factor for many chronic health conditions. And we decided to find out how much of this is evident from our patients. So the main purpose of the study we did was to quantify burden of tobacco use among people with tobacco-related illnesses. And the purpose was to see how much this can strengthen cessation programs as we provide healthcare. So we estimated the prevalence, patterns, and correlates of tobacco use among tobacco-related illnesses at 4 national referral hospitals in Kenya. Next. Next. This study was a cross-sectional study. This study was a cross-sectional study conducted among hospital patients, and we decided to focus on cardiovascular diseases, some identified cancers, chronic obstructive pulmonary disease, and tuberculosis. We went to our 4 referral hospitals in the country, and in terms of exactly which type of patients we looked for, cancers, we focused on oropharyngeal, laryngeal, lung, and esophagus. Cardiovascular diseases, we focused on myocardial infarction, stroke, peripheral arterial disease, and then chronic obstructive pulmonary disease, which we also tried to define clinically as chronic bronchitis and emphysema, especially for situations where we could not confirm COPD by lung function test. And we also focused on pulmonary TB. The patients we focused on were adults 18 years and above, and they could have any of those conditions. And they also had to consent. Next. So when we went out there to the 4 referral hospitals, we managed to enroll about 2,000 patients, and the males made up 61% of these individuals. Ages above 60 were about 46%. And among these individuals who had the tobacco-related illnesses, current tobacco users were about 6%, and former tobacco users were about 40%. Among them, 56% had used alcohol, and then they also had comorbidities on top of the tobacco-related illness that we identified among them. Most of them had been diagnosed with the illness in less than 5 years from the time we were meeting them. Next. What were some of the characteristics of tobacco use among them? Next. Some of them, we asked the behavior of smoking among them, especially among the current users. And those who were smoking within 30 minutes after waking up were about 68%. And apparently, this seemed to be the same proportion among those who were using smokeless tobacco. Within 30 minutes after waking up, 68% would use the tobacco. And on average, cigarettes used per day were 7.7 sticks. And among them, those who had attempted to quit smoking or use of smokeless tobacco was 60%. Next. We also tried to find out the burden of tobacco use among these patients by the tobacco-related illnesses. So from this table, looking at the third column, ever used tobacco, we noted that among individuals who had peripheral arterial disease, about 53%, about 52.8% had ever used. And then another of note was laryngeal cancer, about 60.7%. And then chronic bronchitis, about 60% actually. And then emphysema, about 54%. Next. We then tried to find out what are the predictors or the likelihood of patients who have tobacco-related illness being tobacco users. And we identified some of the predictors. One being old, 60 plus years, older age. I believe the initiation of tobacco may have started earlier on in life, and towards the old age is when we are getting the illness. And then the other risk factor was if you are not married, you are more likely. The odds of being a tobacco user was more likely to be be among the patients, meaning that being in a married state was a protective, kind of a social protective measure to prevent tobacco use. And then an odds of using alcohol. Actually, if you were to use alcohol, you are more likely to also be a tobacco user. I guess the social behavioral characteristics that lead to tobacco use and addiction could also be the same in terms of alcohol use. Next. So in conclusion, we found that among the tobacco-related illnesses in the national referral hospitals, the top 3 conditions were cancers of the oropharynx, the nasopharynx, and the lungs. And we also found that about half of the people who have tobacco-related illnesses, that is 46%, were tobacco users. And then we also concluded that there is a higher chance of one to be a tobacco user among these patients with tobacco-related illnesses, especially if you are older than 60 years, if you are using alcohol, the male sex, and also not being in a marital union. Next. We then recommended that we need to strengthen our strategies or interventions to prevent initiation of tobacco use. And then we also need to sustain tobacco use screening among our patients when we see our patients in our clinical setting. And we also need to promote cessation programs. Probably we integrate them into our health facilities or our workplaces, and also in our community settings. We also recommended that we need to put in control efforts among our patients with tobacco-related illnesses, with a key focus on men and alcohol users. Next. This slide just brings out some of the outputs we have made out of this study, and they are found on the website, which you can refer to. Thank you.
Thank you so much, Jane, for that presentation. I can already see that there are some questions that are coming in through the Q&A function. So I would encourage participants to continue sending those questions through. We are keeping track. If we could go next to mortality.
Hi, everyone. My name is Lazarus, and I want to present this. I have this presentation on tobacco smoking attributable mortality. It's a little bit different from what Dr. Ong'ang'o has, which is primary data. This is kind of a bit of modeling. Next. So our objective was to quantify the excess mortality and disease burden caused by tobacco smoking. specifically, we wanted to identify these diseases, determine the population patterns of tobacco smoking, establish the quantitative relationships, and then quantify the mortality attributed to tobacco smoking in Kenya between 2012 and 2021. Next. So the diseases, as Jane has alluded earlier, Dr. Ong'ang'o has alluded earlier, we looked at these diseases that are kind of related to tobacco smoking, the TRIs, tobacco-related illnesses. These are the cancers, the cardiovascular, the CVDs, the chronic respiratory diseases, TB, and we also looked at the diabetes mellitus. Next. So the method is a bit mathematical. We used the prevalence survey-based analysis model. So kind of we, from the Ministry of Health, we looked at, we got that data that had all-cause mortality from the 47 counties. These are hospital records in the 47 counties between 2012 and 21. Now to calculate the PAF, which is population attributable fraction associated with tobacco smoking, we leveraged Kawini, are we good? Can you? We leveraged on the surveys that had already been done, especially around in the mid of that decade, the 2012 and 2021. We had the 2014, the GATS survey, the Global Adults Tobacco Survey, and also the WHO STEPS survey of 2015. So these gave us estimates of the prevalence of smokers around the decade. And then we also scored the literature, especially from the US Surgeon General report of 2014. We were able to calculate we were able to get the relative risks, the risks that are the risk of death from tobacco-related, I would say, tobacco-related deaths. So with our odds and gender-specific and age-specific ratios, we were now able to get the attribution of how much can we attribute, how much deaths can we attribute to tobacco. Next. So kind of the first section, the first step was to get the data sources. We talked about the GATS and the STEP survey, and also the tobacco, to give us the tobacco prevalence, age and gender specific stratification also for the relative risks, and the category of smokers, whether you are never smoker, former smoker, or a current smoker. This is all-cause mortality data. Next. So the calculation per se is the smoking attributable mortality is the formula would be the observed mortality, especially from the all-cause mortality, from the counties, and also using the PAF. And the formula for the PAF is the proportion who are never smokers, plus proportion who are current smokers multiplied by the relative risk. Kind of the formula is there. That's the formula that is being used for prevalence surveys. Why we chose that formula is because we do not have cancer records, especially cancer records are not so collected very well, especially in Kenya. This one was also completed to by Dr. Maina. in the first presentation. Next slide. So the key findings, the magnitude of smoking attributable mortality, actually the attribution for people who are aged 35 and over in Kenya is about 16.5. So that would mean for 100 people who die from these diseases, 16.5% would be attributable to smoking. And then we also compare this with the trends of mortality and with the trends in mortality. We looked at what the attributions that have been done by other studies, and we found that there were similarities. Next slide. So this is the all-cause mortality, but kind of looking at the four major areas: the cancers, the CVDs, the CRDs, and the TB from 2012 to 2021. And you can see that the CRDs were kind of up. There was a valley in 2017. I think that was in 2017. There was a nurse strike in Kenya. That's why we are seeing that dip there. Move on. So that's one of the data sets that we used. Next. And this is the average from the average smoking prevalence that we got from the GAD survey and the STEP survey. Next. So using those two, eventually now we could get the attributable smoking patterns. Next. Well, in conclusion, from this modeling, we could establish that smoking attributable mortality is a health priority in Kenya. We need to find interventions that help existing smokers to quit and also to deter non-smokers from starting. Next. So these are the institutions that we collaborated with to come up with this. Thank you.
Thank you for that, Dr. Lazarus. And again, I can see we are continuing with engagement in the Q&A function. Let's keep at it. The final presentation is by Dr. Mwai. And after that, I will bring some of the questions that have been asked but not yet addressed in the Q&A. I can also bring them to voice at that point. Dr. Mwai.
Thank you very much, colleagues and participants. So I present on the economic cost of tobacco-related illnesses in Kenya. Of course, this is sprouting from the past two presentations that have been made by my colleague. And while my name appears here, the team that have been acknowledged by Lazarus is the same team that we have worked together on this topic. Next. So it is important to begin by noting the fact that tobacco remains a key significant risk factor, as has been highlighted by my past colleagues, in relation to the existence or preference of the non-communicable diseases. And you find that approximately 8.5 adults in Kenya use tobacco. And of course, with the different distribution across the genders, 3.6 of the youth aged between 13 and 15 use tobacco in Kenya. And of course, the preference is a little bit more higher for boys compared to girls. So tobacco use imposes economic challenges, and this is where you could get challenges from or costs from the healthcare that people purchase after they get ill, the productivity that get reduced when people get sick, and this of course have impact on the growth of the country. And then this become important that we look at given the positive of tobacco. When I say positive of tobacco, I mean, of course, that it creates also some jobs within the market, vis-a-vis the negative impact of tobacco. We see then, is it a net profit, or is it a loss, or is it a gain, or is the country losing by having the tobacco market? Please. Next. So we moved towards estimation of the economic impact of these diseases that are caused by tobacco. And the first thing we looked at was the cost of tobacco, which is estimated by capturing the health cost, as I have highlighted, and also the losses that come from productivity. And this is either through absenteeism or presenteeism. This is when you are either at work, but you are less productive in terms of your optimal level. Or, on the other hand, you have been sick and you are unable to come to work, and therefore you lose entirely the total productivity. In terms of the cost of care, we moved through the estimation of cost of providing care for all these diseases we are talking about that are related to tobacco. And we estimated the staff cost. This is interventions in terms of human resource time, doctors' time, professions' time in treating these tobacco-related illnesses. The consumable cost. This is the cost of items that they actually consume. The medicine that are dispensed to these patients. The overhead costs that are actually accrue to the healthcare facility that is providing services to these people who are sick from tobacco-related illnesses. And of course, the capital costs. This relates to the facility as well as equipment that are there. So the general method was activity-based costing. We went out to collect the costs, itemized cost, so to speak, for each of these diseases, and estimate activity-based costing for the cost of treatment. Next. So in terms of productivity arising from morbidity, we have two key things there that people in economics use to measure. One is largely disability adjusted life years that brings together the years lived with disability as well as the years lost. So when you add the years lost plus the years lived with disability, you get what we call the DALYs. These are disability adjusted life years from the tobacco-related illnesses. And therefore, we estimate both then the morbidity and the mortality component of these diseases that are associated with tobacco. Next. So from the costing, we focused on the diseases that you see highlighted on my left. And these are the same diseases that Jane highlighted earlier in her presentation. And the first column captures the staff cost. The second cost, the first column captures the disease type. The second column is on staff cost, followed by consumable cost, medicine cost, overhead cost, capital cost, and the total. And just to highlight that, you see the cost of treatment for the lung cancer is the highest at $365,000 per person, followed by the cost for esophageal cancer at $7,000. Followed by esophageal cancer at 6,921. These are in US dollars. And then peripheral arterial disease at 6,437. The other disease that is next is cerebrovascular accident, which is a stroke at 5,631, and myocardial infarction at 4,785. Here we estimated what the cost of addressing or treating these diseases per person, per episode. And this is what you see in the far left. And this is from the activity-based costing as highlighted earlier from the methodology that was adopted. Next. From there, we moved to looking at what is the impact of this. And we find the units presented are in millions of US dollars. And we find that tobacco, the first columns have tobacco attributed illnesses. This is monetized dollars gained annually. And you find that the distribution is clear with a spread ranging from the annual gain coming from 148.62, this is $1 million, to $380.12 million. With this, we add the cost of care, because so this is what you lose through productivity, and then the middle presents the cost of care. When you add the two together, then you get the total cost that is attributable to these diseases. And from the aggregate down, you'd see 544.74. Of course, these are adjusted from the epidemiological model that Lazarus have already presented. So that's the low. The medium is at 6, you see from the far right. So from there, next, from there, we move, having looked at the cost in terms of provision, and then we have looked at the total aggregate cost. Then we come to the results, which is a cost-benefit ratio of having this disease. Find that tobacco related illnesses are associated with losses, as we have estimated, presented, and a high of $756.22 million in an economy. But also there are benefits that accrue to the GDP due to the existence of the market for tobacco. And that GDP growth or market gain, if we may call it like that, for the period that we are talking about, then it gives us $252.93 million in the low, and a high range of the same in terms of the gain that we get from the market. Then we calculate the net loss for tobacco use, which is the difference between the first low and the second low, which again give us value of $291.8 million and a high of $503.29 million. So when we calculate, then does tobacco help us in terms of aggregate economic growth? Then we realize that in an expected way, we see that despite the fact that we are getting some growth or some development by having tobacco market in country, we realize that in terms of losses that you get within the period, you realize that the benefits are lesser compared to the gain, with the cost-benefit ratio ranging from 2.2 to 3.0. So that means that for every 1 shilling you spend, you lose 2.2 shillings. Or for every dollar you commit into this investment, this utilization of consumption of tobacco, then you find that you lose up to 3 shillings. So that is the range between 2.2 and 3.0. Next. So with that, we asked ourselves then, what does it mean for our good country, Kenya here? And the first thing is that we need to actually strengthen tobacco control. The productivity losses associated with the tobacco, because even if they are 3, 4, 5, or 10, farmers, when they leave farming for tobacco, I mean, of course, they need an alternative source of income. The second thing is to focus on indirect cost reduction. And here we are talking about the impact of tobacco use into productivity is significant. And we should aim to actually alleviate the economic burden that tobacco has within our market. The other is emphasize prevention efforts. And here we talk about investing in programs targeting tobacco use to reduce the economic burden on the society and healthcare system in general, and therefore realizing on the reverse or reciprocal of the same, so that you get the 2.2 shillings for one or 3 for 1 by actually reducing the usage of tobacco within our market. The last, we talked about healthcare cost management. And we realize that although we want us to have a tobacco-free society, we still have tobacco consumers as of now, and they are actually, in which generally is catastrophic, if you may put illnesses. So in this, we talked about exploring the ways that would be feasible to actually address the high cost of treatment associated with the management of these diseases that are related with tobacco use. So those were our results. Next, so to speak. Thank you very much. Over.
Thank you so much, Dr. Mwai, for that presentation as well. I would like to bring some questions to voice, and maybe Dr. Mwai, if you could start by just trying to type a response, or maybe let's just, could you please turn off your video? I think the internet is a bit shaky, Dr. Mwai. Okay, the question to Dr. Mwai is, could you expound on what you mean by cost per person per episode mean in relation to treatment? Dr. Mwai? Okay, we'll come back to that question shortly. Dr. Maina, there are some questions for you before you could access the chat, the Q&A function. So we have Wasihun Belay ask, major barriers that countries face in having strong and effective policies for prevention and control seem to be intertwined with structural determinants for governments to fund. So why are national governments held accountable for funding NCD's prevention and control, including tobacco control?
Thank you, Winnie. Can you hear me?
Yes.
Let me not put my camera because my internet is also very weak. I think the question is how can government, not why, because I may not be able to understand why government behave, how they behave, but I can say how that they can be held accountable. I think since 2011, when we had the UN high-level meeting on non-communicable diseases, a very strong political declaration was passed. However, when you look at the country by country, the level of implementation of various political declarations has been wanting. It is upon us as the experts and the stakeholders in the countries to carry out a lot of advocacy. And I call upon those of us in this meeting who are in the civil society, part of the public health field, to really focus on accountability of countries to implementation of political resolutions and declarations that are adopted at international forums, sometimes some of them signed by heads of states and governments. If only we were to start there, then we would ask ourselves, why are the ministries of health, for example, which is where non-communicable disease prevention is domiciled, not investing in non-communicable diseases? And I think this webinar today is trying to tell us that we need to generate data that informs policy and actually brings out the clear picture. Like I said in my presentation, in most countries, there is lack of reliable data on non-communicable diseases. And even when it is available, it's totally outdated. So we need to generate evidence that informs policymakers and create a case. What is the economic case? Not just saying NCDs are killing so many people. Everybody knows that cancer kills. But what is the economic burden of this disease to the country, to the family, to the community, and to the individuals? This is the information that we need to actually carry with us. The other question that was directed to me was about illicit trade. How can countries tackle illicit trade in tobacco products and nicotine products, especially in some countries in West and East Africa? We have a solution. In 2012, at the COP, we adopted the protocol to eliminate illicit trade in tobacco products. This protocol, which is a treaty within the FCTC, provides a very good policy and also legal framework we can use actually to prevent illicit trade. Article 8 of this protocol talks very clearly about implementation of a government-controlled tracking and tracing system. If regions were like West Africa and East Africa and Southern Africa were to come up with harmonized directives or policies on how to track and trace tobacco products and nicotine products across the whole supply chain, then we'll reduce the level of illicit trade. Finally, is that we have varying pricing and taxation of tobacco products across various countries. You'll find that as you cross the border from one country, and you know we have porous borders, the prices of tobacco products are quite varied. You'll find one side of the border, it's very cheap. The other side, there's good taxation. So there is encouragement or incentive for people to actually carry products from one side of the border to the other side. If we were to harmonize taxation across regions, for example, in the East African community, if you have to have the same level of taxation in Tanzania, Uganda, Kenya, Somalia, DR Congo, Burundi, Rwanda, and South Sudan, and all of them, the pricing or the cost, the value cost of tobacco were the same, there would be no incentive for anybody to smuggle goods across the border. We need to speak about harmonization of tax policies. We need to talk about having a harmonized or regional track and trace system that addressing the control of the supply chain of tobacco and nicotine products. Thank you.
Thank you so much, Dr. Maina, for those reflections. I'd like to pose a few questions to Dr. Ong'ang'o that I can also see from the chat here. Dr. Ong'ang'o, the first question is, what was the percentage of passive smokers diagnosed with cancer? The other question that I also see is directly for you is by Francis Bolly here. Why is the age of respondents kept over 35, given that the age of consumption is 13 to 15 in several countries? How long does it take on average to contract the diseases mentioned?
Thank you. On secondary exposure to tobacco use, we did ask that question among our patients, and about 20% of our respondents gave us exposure to secondary exposure in the house, in households. And also we had about 10% talking of exposure at workplace. So that was just a description from them. But yes, it is there, secondary exposure at household level and at workplace. Then The other question was about age. Our study, we took up individuals who are 18 years and above, and you realized that when we went to the hospital, our entry point was by identifying the disease first, the tobacco-related illnesses. And when we identified them, we found that people who were above 60 years were about almost half the number of our, actually there were more than, there were about 46%, let me say about 46% of our 2,000 and so patients were ages 60 years and above. And we thought that yes, initiation of use of tobacco starts very early, but the disease condition develops much later in life. Yeah, so this was not a big surprise in the sense that from the time of use, initiation of use to the time that the condition is developed could happen much later in life. I think there was, Winnie clarified to me, there was something you mentioned 35. I'm not very sure what you
Yes.
asked.
I think the question was, what is the age of respondents kept out over 35, given that the age of consumption is 13 to 15? And I think you've responded accordingly. But I think that 35 might also refer to the mortality study where Lazarus primarily focused on 35 and above, those who died by 35 and above. But thank you for that.
Yeah, probably Lazarus can explain the 35.
Yes. Thank you, Jen. And Lazarus, as you come to explain the 35 and above, I see there's a question that you've already responded to, where we have someone from Ethiopia requesting capacity building. But other than that, I'm also curious about how often should these mortality studies be conducted? Given that the study you did was 2012 to 2021, when should we be due for another study? Lazarus?
No, thank you very much for those two questions. I think in the modeling tobacco attributable mortality, the age cutoff of 35 and above is commonly applied. This is because the tobacco-related diseases such as cancers, COPD, CVDs, often develop after many years of exposure. You would say that the initiation of tobacco use often begins between maybe 13 to 15 in several countries, but it takes 2 to 3 decades, okay? Take 2 to 3 decades of sustained tobacco use before the major chronic diseases linked to tobacco manifest. So that's why in the modeling, we don't look at the deaths before 35. We are assuming if you began smoking at age 15, it would give you maybe 20 more years for these tobacco-related illnesses to manifest. What was the other question?
The other question was, when is Kenya due for another mortality study? Given that the last study you did was covering 2012 to 2021, when are we due to get another one?
Yes, I think this also ties to the first question that was asked about availability of data and efforts to strengthen countries to be able to attribute, say this is the proportion of people dying because of tobacco use. And I kind of passed the ball to Dr. Maina to maybe tell us a bit of what, let's say, for example, WHO is doing to strengthen countries in to be able to come up with the data or to collect data to be able to kind of quantify how much deaths or how much morbidity are we experiencing because of tobacco use? In Kenya, there is, I would say, if you are looking at TB attributable, there is this data set called TIBU. It's for TB. They are also collecting, they are also asking the patients who have been found with TB whether they've been also using tobacco, smoking tobacco. But in other places, I'm not so sure what efforts they're putting in place to be able to quantify how much is attributable to tobacco use. Back to you.
Thank you, Lazarus, for that. I might not take it back to Maina because I see we're at time, but at the same time, I want to respond to at least one of the economic cost questions to Mwai. Dr. Mwai, are you there? I see there's a question around, could you expand on what you mean by cost per person per episode in relation to treatment? This was from Peter Magati. And could we do this in 1 minute? And while you're responding to that, if you could briefly respond to, I know we engaged Dr. Michael Bocci, who also supported the South Africa study. What lesson did we get from that other study that we used in this study as well? Dr. Moy?
Thank you, Winnie. I'm hoping you can hear me. My internet is also misbehaving. I don't know why.
I can hear you.
But ideally, what we talk about is that we estimated the cost of care for patients who have gone through the full cycle of treatment for these diseases. And that is a cost that we have estimated in terms of US dollars, having to go through the diagnostic procedures as well as the treatment in terms of the medicine that they are given to consume. And we have broken down this into different facets of costs. That's why it's activity-based costing. And this then we tracked the cost that relates to staff, those that relate to consumables, medicine, overhead costs, as well as the capital cost, which is attributable to past investments, but are useful for the treatment of the disease. These largely are equipment as well as the other capital costs. So that's what we mean when we say the total cost that we are reporting as unit cost. Thank you.
Thank you.
I also know Peter, he can reach out to me for more details at any other time. But I hope I've been able to respond quickly to his question.
Thank you so much for that, Dr. Mwai, and thank you everyone for your engagement and just interacting with the content in this webinar. Some key takeaways from the morbidity study: 46% of the patients had a history of tobacco use. Mortality study, 16% of the deaths were attributable to tobacco smoking. And for the cost study, for every dollar gained from the tobacco industry, we are losing between $2.2 and $3. So I think the onus is on us to make a judgment call on how to proceed from here. Some quick next steps from our end, just to again thank you everyone for your engagement with the content, and we will be sharing the slides. I have also been sharing the other manuscripts, so we'll make sure to send all those in the next few days. I would like to also thank the panelists who have taken the time to share evidence to demystify what can sometimes be a complicated topic. So thank you all to our esteemed panelists. And a sneak peek to what is coming up next in the TCDI webinar series. We will be shedding some spotlight on illicit trade findings in DRC and Zambia. So I'm happy that there was a question on illicit trade. We'll be sharing something on DRC and Zambia in the next month, and we will share the timelines in due course, or rather the exact date. Thank you all so much, and have a good rest of your day. Bye. Bye.
Thank you.